5 weeks, depending on where you are, would be the cutoff. If you don't know mom's dates, you use the umbilicus, you use the pubic symphysis as a guide, and just a measuring tape, and so every centimeter above the umbilicus will give you an additional week of gestation. There is a question about whether or not to do it in a 23 to 28 week gestation, because it may not be of much benefit to the mother, because the cardiovascular effects, obviously the baby's not as large, it's not pressing on the IVC as much, and so the cardiovascular effects that you're trying to relieve in order to resuscitate mom may not be as pronounced, so it may not be as helpful. And you have to consider the length of time between cardiopulmonary collapse and cesarean delivery. And 4 minutes is what was suggested, but as you'll see from this study, is it this one or it's coming up? That there are people who've done it well past the 4 minutes and had some interesting outcomes. So this is a table from the 188 cases and looking at who survived. Oh no, this is from the later set, I'm sorry, the 36 cases. And so it gives just different gestational ages. The time is on the left-hand side. So actually, 7 cases were performed over 15 minutes. And they actually got 4 normal infants out of that, 2 with neurologic sequelae, and 1 with respiratory sequelae. So that 4-minute window can obviously be pushed. Looking more thoroughly at maternal causes, trauma obviously being a major one, cardiac collapse, embolism, magnesium overdose, sepsis, anesthesia, eclampsia, spontaneous uterine rupture, intracranial hemorrhage are all causes in this study. Here again, we looked at the time from maternal cardiac arrest until delivery, and you can see the spread. This is a decision table. So obviously, you're making an assessment of mom, but you're obviously trying to do it so that you can initiate standard ACLS protocol. And so really, you're trying to perform the hysterectomy and deliver the baby so that you have better support for mom's cardiovascular system, and you can do your procedures better. So when deciding what we're going to do, and I will say that when I looked at the literature, they did say that you should try to call your closest obstetrician to do this. So if you'd like to undertake it, sure. The fastest way to the baby would be the vertical incision on the skin, as you can see, and then going straight down through the uterus. Just go straight down in that vertical manner until you deliver the baby. That would be the fastest way. They did say that now, since most obstetricians are more familiar with transverse skin incisions and fan and steel, we can probably affect delivery within a minute using the transverse skin incision. So if you have someone who's more comfortable doing that, it's not wrong. There's no one right way to do this. Showing you the uterine incisions, the low transverse is what we typically would use nowadays for a standard cesarean section. Low vertical is sometimes used if we either don't have good exposure, or we have a lot of adhesions, or there's some other reason why we would not want to enter higher on the uterus. And then the standard classical is at the bottom. This is just going to show you the transverse uterine incision, you would make a bladder flap. This is what we typically do. And then use your nuts and bolts scissors and create your bladder flap, pushing the bladder down, because obviously you want to make sure that you're not going to injure the bladder during this. Myometrium is there, you're going to separate that. And then usually we just, after entering the muscle and cutting through the uterus, would bluntly extend the incision. This is what we typically do now, rupturing the membranes, and then using your hand to deliver the fetus, especially if it's in the vertex presentation. If it's not, you need to put your hands in there, grab the feet and deliver by breech extraction. And there we see the delivery of the fetal head. And then of course we can't forget to close mom back up, because you actually, what makes the uterus stop bleeding and what will help to support your efforts to resuscitate mom will be keeping her blood volume in here. So although we probably will be transfusing her, we need to close the uterus after the placenta is delivered. I didn't realize I was missing the slide of the placenta. You have to deliver the placenta. Sorry about that. And then you need to close. It doesn't need to be neat. If it's a peripartum delivery, perimortem delivery, you want to close it in whatever method is quick and efficacious, so that the uterus will, you can try to clamp it down and stop as much bleeding as you can. So that is what I have. So thank you.
Are there any questions for Dr. Wilcox? Dr. Jamie?
So for perimortem C-sections, I've always been taught you just cut from xiphoid to pubis.
Right, which is what I said. You
Okay.
just cut straight down vertically.
Okay.
However, when you're reading some of the papers, if you have an OB and you're calling the OB down to it, we're not really used to doing that, to be perfectly honest with you. And they said you have to effect delivery in a minute. And if we can effect delivery using a transverse, because that's honestly what people are used to doing, that's okay too. Of course, they're probably just not trying to bind anyone. If it's ACOG, they're not trying to legally bind us to anyone one way. Yes.
The guidelines on giving ROGAM in the first trimester, are they based on those studies from 68 and 1974, or do the new guidelines have additional?
So our last guidelines are from 2006, and there are some more recent papers, but I think that because when someone is alloimmunized, it really creates a major problem in all subsequent pregnancies, that we really would err on the side of just giving it. And I haven't really been keeping up with the ED literature, so it was actually a surprise to me to even realize that this was out there, because it's such a standard part of our practice.
But like other guidelines from other countries don't recommend it, right?
Yes, as she showed, that is true. However, knowing that some of our other colleagues from across the pond, so to speak, are ahead of us in some other things like DVT prophylaxis, they were a little bit ahead of us, hypertensive disorders. So I do not know, I have not heard, I just came back from ACOG last week, I did not hear of anything about RH, about ROGAM or not giving it, but I can try to inquire. But right now, the standard is the standard, and it's pretty ingrained in the culture. So I don't know. We'll have to see if it changes. But the standard of care is the standard of care right now. So in New York City in 2016, when one has an RH negative pregnant woman who has a bleeding episode, the standard is we give ROGAM. Yes.
Is there a timeline as to when the ROGAM is less effective? Sometimes we have patients that, for one reason or another, their workup is prolonged and they're just desperate to go home and take care of their other child. And I've had several people sign out against medical advice while waiting to get their ROGAM, which sometimes takes time. Can they come back the next day and it'll still be effective, or 2 days later?
They can, it stays in the system, I mean, I'd have to look this up in a while, I'm sorry, for at least a few weeks, so it should be fine. We typically give it at 28 weeks in normal pregnancy, and again after delivery. So any point where you think the fetal and maternal blood cells are mixing. So the question is, you know, how quickly to get the ROGAM in there so that it's not going to cause mom's antibodies to react, or to at least counteract those antibodies. So probably it's, I don't know, I'd have to look it up, but I would say a couple of days is probably fine.
So can we discharge them and send them to OB clinic for ROGAM then?
I would not do that because a lot of our patients don't follow up. So I would rather you look at why your ROGAM administration is so prolonged. And actually that happened in our ambulatory practice, and we actually worked with the blood bank so that we now have it in our Pyxis machine. So there is a standard that we have instituted now where we are keeping ROGAM, even though we're sending it to the blood bank for testing, even though the ROGAM is coming from the blood bank, pharmacy is stocking it, and it is on site in the Pyxis, because we used to have people waiting in our ambulatory practice for 6 hours, which is crazy. So if this is a problem, we've already set up the system with the blood bank to try to get that. So if the ED needs to also institute that, we can start talking to Dr. Whitsitt and her crew to maybe get you some ROGAM close to the ED, so patients don't have to wait forever.
That would be a life.
Carla, QI project? QI project?
Mona?
So I have a patient that came in and we wanted to give ROGAM to her because her RH is negative, and she was pretty persistent that she knew that she was RH positive. So I kind of looked it up and I heard that there's something called weak D that's pretty common in African Americans. I mean, we didn't have evidence for her. You know, still gave it to her and insisted on giving it to her, but is that something that you encounter commonly? Is that like a real thing? I mean, I just Googled it, so I'm not really sure that weak D is common and you don't necessarily have to give, and some people come back negative, or they
I would think we would need to do some confirmatory testing. I'm not sure. I'd have to get back to you on that. I would think I can tell you the more common problem in our patients is that we have mislabeled specimens and or, you know, somehow confuse patients, and you can go back and you can see the same patient under her MR number have different results of her blood tests. So that's why the blood bank is so insistent that they have 2 specimens within at least the span of a pregnancy because of our problem. And it's not that the problem is in the patient, the problem is us and our processes. But they are pretty insistent on checking it because we have had so many issues with mislabeled specimens.
So weak D is not an actual thing, because the blood bank.
No, weak D is probably there. I'm not able to give you an answer to your question because I would have to look it up. I'm sorry.
Any other questions for Dr. Wilcox? All right,
Thank you.